Hey everyone, and welcome. We're about to dive into a complete study guide for GI therapeutic procedures. My goal here is to break down everything you absolutely have to know, not just for your exams, but for being a safe, confident nurse. This is all about the must-know, high-yield info, so let's get right into it.
So here's our game plan. We'll start with the two big ways we provide nutrition: enteral feeding for when the gut works and TPN for when it doesn't. After that, we'll switch over to procedures that relieve pressure, things like paracentesis and NG decompression. Then we'll cover the essentials of ostomy care, and to wrap it all up, we're going to test your knowledge with a case challenge to really sharpen that clinical judgment.
All right, let's kick things off with our first big topic, enteral feeding. You are going to see this constantly in practice, so getting these fundamentals down, especially around nutrition and safety, it's absolutely critical. Okay, so what is enteral feeding, really? Well, the most important phrase on this slide is functioning gut. That's the whole key. The patient's plumbing works just fine, they just can't take food in the normal way, by mouth. So we use a tube to deliver nutrition directly into that working GI tract. So who are we talking about here? Well, think about patients who physically can't eat, maybe due to head and neck cancers, or those with neurological issues that make swallowing unsafe, like after a stroke. But it's also for patients whose bodies are just in metabolic overdrive. I'm talking severe burns or sepsis, where their energy needs are so incredibly high, they could never eat enough to keep up and heal. Think of this slide as your day-to-day troubleshooting guide. So your patient is feeling bloated, maybe a little nauseous. Your first thought should be overfeeding. So what do? You check the residuals and you slow that infusion rate way down. If the problem is diarrhea, it's usually one of two things. The rate is too fast or the formula is too cold. Easy fixes: slow it down, make sure the formula is at room temp. And for constipation, well, that's usually pretty simple. They just need more water and maybe a formula with a bit more fiber.
Okay, but here's the big one. The complication that we have to be obsessed with preventing is aspiration pneumonia. It's a life-threatening emergency, often caused by the feeding tube moving out of place. So prevention is everything. You always confirm that placement before you start a feed, and you always keep the head of the bed elevated at least 30 degrees. If you even suspect aspiration, you have to act fast. Stop the feed immediately, turn the client onto their side, suction their airway, and get the provider on the phone. Every second counts.
So what happens when the gut isn't working at all? Well, that brings us right into our next section, total parenteral nutrition, or TPN. This is what we use when the GI tract is completely offline and needs to rest.
TPN is basically a custom-made powerhouse of nutrition that goes straight into the bloodstream. It's what we call a hypertonic solution, which just means it's super concentrated. And because it's so concentrated, it would destroy smaller veins. That's why it absolutely must be given through a big central line, like a PICC line. It's got the whole shebang: dextrose for energy, lipids for fats, proteins for healing, everything.
Now this slide really gets to the core difference. Enteral feeds use the gut. TPN uses the veins. It's that simple. And that one difference changes everything, especially the risks. With enteral, we worry about food going into the lungs. That's aspiration. With TPN, since we're bypassing all of the body's natural filters and going right into the central circulation, our biggest fears are a bloodstream infection and major metabolic swings.
Your workflow for a TPN patient has to be meticulous. First, you always prepare by checking the latest lab work, because that TPN formula is tailored to the patient daily. When you administer it, you have to use a special filter, and you never make sudden rate changes. You always wean it up and wean it down. Monitoring is constant. We're talking daily weights and blood glucose checks every 4 to 6 hours. And for maintenance, this is a big one. The bag and the tubing get changed every 24 hours. No exceptions.
And that brings us to this critical safety alert. You can't just stop TPN. If you do, the patient's blood sugar will crash. Why? Because their pancreas has been working overtime, pumping out insulin to handle all that dextrose you're infusing. If you suddenly cut off the sugar supply, all that insulin is still floating around, and it can cause profound hypoglycemia. That is why you always have a bag of dextrose 10% in water, or D10W, at the bedside just in case that TPN bag runs dry unexpectedly.
The complications with TPN are no joke. You've got metabolic issues like hyperglycemia, which is why we're checking those blood sugars so often. An air embolism, while rare, is deadly. If you suspect it, say during a tubing change, you act immediately. Clamp that catheter and position the client in a left-sided Trendelenburg. That helps trap the air bubble in the right ventricle so it doesn't travel to the lungs. Infection is a huge risk because that sugary TPN is a perfect breeding ground for bacteria, so sterile technique is non-negotiable. And finally, you have to watch for fluid overload, listening for crackles in the lungs.
All right, let's switch gears a bit. We're moving on to two procedures that are all about relieving pressure and managing blockages in the GI system.
This slide gives you a great side-by-side comparison. A paracentesis is all about draining fluid, ascites, from the abdominal cavity, usually to help a patient with cirrhosis breathe easier. On the other hand, nasogastric or NG decompression is for when there's an actual intestinal obstruction. We put a tube down and use suction to relieve the pressure from the blockage. The biggest thing to watch for after a paracentesis is hypovolemia. For NG tubes, it's all about managing their fluid and electrolytes.
Your role during a paracentesis is absolutely key to keeping the patient safe. So before you start, you make sure consent is signed, get your baseline vitals and weight, and, very importantly, have the client void. You do not want to accidentally puncture a full bladder. During the procedure, you're monitoring those vitals closely as liters of fluid are slowly drained, and afterward, your whole focus is applying pressure to the site and watching like a hawk for signs of hypovolemia, like a rising heart rate and dropping blood pressure.
Now let's move into our fourth section, ostomy care. This is all about the practical, hands-on skills and, just as importantly, giving our patients the education they need to manage their care confidently at home. This is so fundamental to understand. The location of the ostomy tells you exactly what kind of output to expect. Think about it. An ileostomy is at the very beginning of the large intestine, so it's bypassing the whole thing. That means the output will be liquidy and pretty continuous. A transverse colostomy is further along, so it'll be more pasty. And a sigmoid colostomy is way at the end, so the stool will be almost normal, semi-formed, and more predictable.
Okay, here it is, your high-yield memory anchor for the NCLEX. Lock this in. A healthy stoma should be pink or red and moist. It should look like healthy tissue inside your cheek. Now, if you assess a stoma and it looks pale or bluish or, worst of all, dusky or black, that is a code red. That means ischemia. The stoma is losing its blood supply, and that is a surgical emergency. You have to notify the surgeon immediately.
For our ostomy patients, good teaching is everything. It's the key to their long-term success and quality of life. So we teach them to empty their bag when it's about a third to half full to prevent leaks and skin irritation. We teach them how to protect that skin around the stoma. And we talk about diet, especially for new ileostomies. They need to avoid high-fiber foods at first to prevent a blockage. And finally, don't forget the psychosocial part. Encouraging them to connect with a support group can be a total game changer.
Okay, deep breath. We have covered a ton of information. Now it's time to put it all into practice, just like you'll have to do on the NCLEX Next Gen. Let's see how well you can apply this knowledge.
All right, here's our first question. Your patient is on TPN. The bag has been hanging for exactly 24 hours, but there's still 400 milliliters left in it. What are you going to do? Think back to our TPN safety rules. What is the absolute priority here? What's your next move? The correct answer is A. You have to remove the old bag and hang a new one. That 24-hour rule is non-negotiable. And the reason why is infection risk. That high concentration of dextrose and TPN is like a 5-star buffet for bacteria. Letting it hang any longer, even if there's solution left, drastically increases the patient's risk for a central line-associated bloodstream infection. Okay, time for our final case. I want you to really picture this. You're caring for a patient who is 2 days post-op from getting a new ileostomy. They tell you they're having abdominal cramps, their belly looks bloated, and this is the big clue. There has been zero output from that stoma for the last 6 hours. What should be going off in your head right now?
You've correctly identified the classic signs of a potential intestinal obstruction. This is that clinical judgment moment. You need to pull together everything we've talked about, your assessment findings, potential complications, and what needs to be done right now. So, what is your immediate next action as the nurse? What do you do first? This is exactly the kind of critical thinking you'll use every single day on the job and on your exams. Go ahead and think it through.